Hello and welcome to a rather special episode of Health on the Line, which you're hopefully now listening to as you pack your toothbrush ready to join us in Manchester for the annual NHS England and NHS Confederation joint conference, NHS ConfedExpo. There will be so much to get your teeth into. Did you see what I did there? Sessions on integration, collaboration, transformation, improvement, all being debated on the eve of the government's 10-year plan for the NHS and with the small distraction of the comprehensive spending review taking place in the background. Well, I can't wait to experience it with all 8,000 plus of you who will be there. I really hope you get lots out of it. And if you're not able to come, there will be online content to follow. So ahead of ConfedExpo, I was delighted at the end of last week to be joined by Sir Jim Mackey, Chief Executive of the NHS. I talked to him about the state of the NHS, where we go next, and his views on leadership. Welcome to Health on the Line, Jim.
Hi, Matthew. Good to see you.
I'm just going to say a little bit about your background, Jim, for anyone who doesn't know. You were, until very recently, Chief Executive of Newcastle upon Tyne Hospital's NHS Foundation Trust. You're technically on secondment from that role. You're also previously Chief Executive of Northumbria Healthcare. And during that time, you've been National Advisor to NHS England on elective care. And before that, you had a 2-year secondment as Chief Executive of NHS Improvement. And now you've got this critical role at a critical time as Chief Executive of NHS England. This will be your first ConfedExpo as Chief Executive of NHS England, Jim. We'll be looking forward to your speech. But what's the core message you want to get across to us in Manchester?
We're grappling with the minute, so you understand what it's like, Matthew, is we've got trying to work out what I'm going to say, how we're balanced with the spending review and 10-year plan, all those sorts of things. But I think the key things I want to just try and get across and then also pick up in the interactions in the informal stuff is we are trying really hard. Everybody recognises it's really difficult at the minute, but we're trying really hard to work together and alongside each other to do what we need to do in tricky circumstances, and hopefully people can see and feel all of that. Working also really hard at the centre to create the conditions for success to enable people to do what they need to do, and as part of that, get out of some of the space that we've ended up being in the centre. And also linked to that, and hopefully the 10-year plan will really stimulate this, just generate and help and generate that sense of ambition for the service and for the future, and the hope and optimism that things might be tough now, but in the foreseeable future they can be a hell of a lot better. But that's all of our jobs. It's not a single person's job. It's how we all respond.
That's great, Jim, and very powerful messages. Now, you've been in this role for a few months now, a couple of months now. What's been the kind of biggest learning that you've had since you've taken on the role?
It's a really good question, Matthew. You're learning all the time of these things, and I found when I did the NHSI job and a bit with the elective job, when you're in the national world, it is different. You're using different skills, and you can say things that get very well analysed and magnified and misinterpreted sometimes. So there's a bit of that, me just sort of relearning that. Have to be aware of that, so I can say some things and they can become a really big thing really quite quickly when you didn't intend it, or at other times it can kind of get lost in the noise. I think just trying to understand how it actually all works. I've been attached to the national system for quite a while, in the elective role, but it's not until you're actually in it can you really see how NHS England works, the relationship with the department, relationship with government, and I've learned a huge amount from that. It's just in a very short space of time. And the complexity is really weird as well. We all chief execs everywhere live with complexity and ambiguity. But this is, again, really quite different. It's at a different order that I've ever experienced. Partly about government, where they are in their cycle coming up on an anniversary, where we are in terms of international security, defence, what that means for the economy, the position we're in, public response, public attitudes to sort of just feel really complicated. So I feel like I've had a bit of a need to adjust and reacclimatise to that, but also not really the time to think about it too much because it's been so fast paced and there's been so much to do in such a short space of time.
Jim, we're speaking just before the publication of the UEC delivery plan. I think you've just done a briefing on it, but the broadcast will be going out after that. Tell me how the UEC delivery plan reflects some of those kind of shifts that you're trying to make in terms of the way in which the centre acts and the centre is perceived.
Yeah, so that's a really good point. And this is a plan that was theoretically ready to go before I got involved. So it's been there and there or thereabouts for several months, but been going through the machine. That's given Sarah Jane and Julian and other colleagues a chance to really work with people on the ground to make sure that it's realistic, it's stretching but realistic, it's helpful, it doesn't jar with people, or chem as well. So that's one thing where we're really trying incredibly hard to make sure that we do this as much together as we can, rather than it's just a view, it gets sent out, it is what it is. People make it whatever they want of it. Much more interactive, collaborative alongside each other has been the key point. There's some subtle things in that, like it immediately doesn't ask for loads of returns and reports. It's not something that is pointing upwards immediately. It's deliberately trying to help people point locally and work locally. We'll support, we're being accountability as always, but hopefully people will be able to see and feel that as well. It doesn't immediately provide a load of templates. The other bit that we're trying to do in everything is just get the balance right between we are where we are and it hasn't been great. It's been tough for everybody. We need to improve. We've got to improve with some pace and stretch ourselves, but that can't ever look or feel beyond reach or unreasonable or just Pollyanna-ish as well. So I think trying to get the balance right on that, and you know what that's like. Sometimes you feel out of balance. Sometimes you go too hard. Sometimes too soft on it all. But the team are working really hard with colleagues to just try and get that balance right.
Yeah, and reading through the document, Jim, I noticed that subtle but really important shifts in the kind of tone of that. I mean, I used to think when I listened to NHSE senior folk in the past that there was this kind of disjunction, because there used to be kind of two messages. One was, we're doing really well, and the other was, we really need help. And you kind of thought, well, how did these things add up? Whereas what I got from the UEC delivery plan was more, actually, we're not doing very well, and we need to admit that we're not doing very well and admit that we're letting down patients and that the performance is too variable. But actually it is largely within our hands to make a difference to that. That's what it sounds to me like. That's a kind of the shift I'm hearing in your tone.
Yeah, I think that's absolutely spot on, Matthew. And you reminded me when you were talking. I was in Bolton on Tuesday. I went to see colleagues in the Northwest. Had a really great visit to Bolton. And it was a really good reminder that at times in the national world, you can feel like you need to tell people to do stuff without realizing they're actually already doing it, or hope that something gets fixed and it's already being fixed. What the issues are, things that you're not seeing in the performance returns. There's a different set of issues to the ones you can recognize and describe. So we are trying to be realistic about that. It's messy, it's difficult. I don't think we can actually fully solve our problems unless we're honest and we can, say that they are what they are. The public can see it, our staff can see it every day, but use that as the platform to push on. And it's that releasing the local ambition thing I saw a load of in Bolton. It was a really fantastic few hours. It was really lovely, and the team were great, and the staff on the ground were absolutely brilliant. Really bursting with ambition. And that's what it's all about, and that's what we really want to try and generate more of in this next period.
I think this point about ambition and also about your style, let's take it into the kind of relationship that you have to have with the politicians. Obviously, NHS is moving into the department. It was clear from the outside, and I've been in this role now for more than 4 years, that there have been times when there hasn't been an enormous amount of trust or even necessarily mutual respect between, the politicians and ministers and people high up in NHSE. Now, your focus on delivery, your focus on sorting out the finances, your focus on hitting the key targets will be music to the ears of ministers. But part of the reason that's important is so that when you say to them, you need to be realistic about what's possible in the context of the spending review or the 10-year plan, that they listen to you, that they know that you wouldn't be saying to them, certain things aren't possible if it really wasn't the case. That's an important part of your role, isn't it, Jim, is to help the politicians to be realistic about what we can achieve.
Yeah, absolutely. And that's, with the NHS England change, I've been asked a few times about, does this make it harder? And, am I going to find it hard to stand up to the politicians and, those sorts of things? And it's just really not like that. Everybody understands we're in a difficult position, not just the NHS, but the broader stuff that we're talking about, the economy and stuff. And there are always choices. We always have choices. There are always ways through situations. And I think working at a trust level, people are actually really good at that. They're confronting choices all the time. They're having difficult conversations all the time. But they're having them out in a professional way, agreeing what they need to do. Sometimes knowing full well it might not work and then have to course correct. And that's not terrible. That's just life. My time working with the political team, previously in the elective role and now in this role, they're actually really good at that. They're sensible, mature, intelligent, challenging, and can see that sometimes it's not completely binary. It's not choice A or choice B, or it's not simple. If it was simple, it would all just be sorting itself out. We've got a lot of complex interactions going on here. But it is absolutely my job to make sure that we don't just drift into assuming something's going to happen when it can't, or we start being unreasonable in expectations. But we also we're not defeated before we start. It's just hard to get the balance right. We've been doing quite a lot of that all week, as you can imagine with the 10-year plan and the spending review and where we are, and just trying to get that balance right.
That's really tough. But my sense is, Jim, that the trust that you've got with the politicians makes it easier to be credible when you say those difficult things, talk about those hard choices. Let's go to the 10-year plan now. So the kind of two contrasting perspectives people can have in the 10-year plan and what it can achieve. And one is, well, let's be realistic. The next 3-4 years are about 3 years are about recovery. And we can only really just kind of pick at the edges of reform. It's just not realistic to sort out the finances, hit our targets, and expect to do radical change at the same time. And then there's another view. And the other view is, look, if we don't start moving on reform, the day after the 10-year plan is published, then people will say, yeah, but the things the plan are supposed to achieve, particularly the left shift, we've been hearing about this for decades and it never actually happens. So unless the plan shows real change over the next few years, it will lose credibility. Where do you kind of stand in that conversation?
So I'm fighting with myself about that every minute of every day at the minute. Speaking completely honestly, 10 years is a long time. It's 10 years this year that I started at NHSI. And, it feels like hundreds of years ago. And you think of, at that time, we didn't have the ability to do Teams calls even, so there's a lot can happen in 10 years. And it does feel, in NHS terms, a really long way out. And also, if we're really serious about generating our own ambition and really trying to step up to what the public expect, a lot of it can't wait. And we don't want to hold people back. And in my former trust life, I'd expect to read the plan and want to do all of it the next week. And again, it's about balance, isn't it? Just about being, we've got the money that we've got now, we've got the workforce that we've got, we've got the physical buildings, all those sorts of things. We've got a spending review that covers the first part of that plan. I think it is actually a bit of a hard sell to say you've got to wait 3 years while we dig out of this before you can see any results. We're going to have to go much harder than that in reality. But also some of the things that we're going to set out in the plan will have a natural, quite long gestation. It'll take time to create and build, and are going to necessarily have to follow a few sequences of events where we'll build confidence, momentum, infrastructure, technology, those sorts of things. But what we'll not be doing is saying it has to be absolutely the same everywhere. It has to be the same pace everywhere, which is one of the things that I think is one of the good changes, and I think really quite liberating, just trying to let people get out of the blocks and find their own way. And again, just going back to the Bolton thing, spent a lot of the last few weeks talking about neighbourhood care. I went and I saw it, bit of it in Bolton, and it's not exactly the same as we've been talking about it nationally, but it's not exactly the same in my old patch either. But shouldn't believe these things aren't happening. They're actually all happening in some way. We just want to take them on with a different level. In an ideal world, would like to have an SR that completely supports the plan, has all the money in place, the plan gets published, everyone go hell follow the straight away and deliver it all. Life's just not that straightforward, is it? But the NHS will do its best and we'll smash it. And really confident in a few years' time we'll be looking at this tricky period as actually probably quite a helpful part of a process that give us a bit of a jolt and we'll get out of it.
If we think about financial sustainability, Jim, obviously the 10-year plan is going to have lots of excitement around technology and AI and genetics, and that does offer transformative possibilities. But also we know the history of the NHS is that generally technology and innovation, biomedicine actually, in some ways increase demand. They expand the range of things that we can treat, what people expect of us.
Yeah,
I think, I think we at the Confed believe that in the end, the really big shift has got to be that left shift. We've got to get better at working with people to prevent and to manage illness and to reduce unnecessary demand, particularly unnecessary demand on acute hospitals. And I'm interested in your message there. So again, if you look at the UEC plan, one of the things that I thought was great about it was it recognised that UEC is a systemic issue. It's not just about flow in hospitals. Of course, that matters. But, the planning even gets into issues like out of hospital placement, out of area placements for people with severe mental illness, recognising the way in which things going wrong in one part of the system then impact in others. But yet, Jim, when I talk to leaders at the moment, under financial pressure, under operational pressure, I do hear them say, look, in this environment, I've just got to focus on my organisation. I've just got to focus on that which I control, that which I'll be held to account for. I just don't have the energy to be leaning out to other parts of the service, other part of the system. Some people have interpreted the shifts in ICBs as a moving back away from the kind of ambitions around system working. So Jim, what's your message to leaders about how they balance their responsibility to run their organizations efficiently, but also the responsibility to work with their partners to change a system of care that's just not working at the moment?
Yeah, well, it's a really good point. And when I was coming through as a young director hundreds of years ago, working for Sue Page, who was my chief executive at the time, and Brian Flood was my chairman. Brian had been a council leader. Sue was really system orientated, very used to talk about whole systems all the time. We were a trust that had its boundaries, but it was our job to work with accounts. I knew it was trained into me, it's built into me. It was our job to work with accounts. We ran most of the community services, but when we didn't work with the community providers, work with all the other agencies in that place, it's just always been part of the job. And it is in certain parts of the country. You can see that's really hardwired. You'll run out of road just trying to deliver everything internally. But in the last few years, partly because it's been so hard and partly a COVID thing and stuff, people have at the same time become, I think, at times a bit harder about the boundaries. But also a lot of people were telling me there's an awful lot of wasted meetings, pointless meetings, lots of meetings that didn't have a purpose. And there's nothing worse for busy people is to feel like you're wasting your time. So what we're trying to do is to have a bit of a rebalance and say this isn't all about just delivering within your boundaries or being in external meetings 4 days a week. Get the balance right, but there's got to be a point. There's got to be a purpose. Challenge it. If it's not delivering what, or you're not sure what it's supposed to be delivering, challenge it and don't do it. Have a think about what's the point of this interaction with the council or with the ICB or with another partner. We've all got to be more ruthless with our time and the potential for an impact and what it's doing for the population, our patients and our staff. So that's really what we're trying to do in all of this. It's not, you've reminded me last time I did a Confed speech, I think it's about 2017, I think it was. And the point of it was about false binaries, where the NHS often portrays things as I can do that, but I can't. That means I can't do the other. It's not like that. It's not, it's just not how the NHS works or any senior leadership role works in reality.
Is this therefore a kind of cultural change? Is it to do with the incentives? Is it to do with the financial flows? I mean, I think I've quoted this before, and I do it with due deference to the leaders that I represent. I mean, I think the leaders I speak to in the NHS are amazing people doing fantastic work, often in incredibly tough circumstances. But someone I spoke to who work with the NHS leaders said similarly very, very positive things, but then said that the one thing they thought was less positive was how quick NHS leaders could be to blame other people in the service for the problems that they had. That does feel like it's a cultural problem, and sometimes something that's been reinforced by the way our incentives and accountability and financial structures work.
Yeah, I think that's right. And I think we've all got a bit blamey over recent years. It's hard to tell how long that's been going on for, and whether it's like in the DNA, we can be very tribal. There's often a council NHS thing goes on, or acute community, or whatever other things going on in the local dynamic. It's an excuse, isn't it? It's a distraction activity. And we were just talking about it this morning, like going back onto the COVID thing too much, but we need to create another moment that's a bit like that, where people actually did just mug in. They're just, clinical staff, operational staff, the regulatory system, local partners, a really good council chief exec friend at the time told me, you make all your friends in peacetime. This is when you find out how good a friend they are. I think there's really something in that. There's really something powerful in that. We're looking after the same people. The population is the same, whether they need the housing repaired or they need us to fix their knee or their eye. Just got to remember that at all costs. And at the minute, people are worried, they're skint, they're concerned about international security, they're worried about waiting too long. Just all like important but fundamental human needs, aren't they? Yeah, that none of us can fix by ourselves. There are some specific things that only we can fix because they're within our complete control. And I think we just have to be a bit grown up about that.
And back to leadership, you've put a lot of emphasis on variation. And I get that completely. And Wes Streeting talks about kind of league tables and cracking down on leaders who fail. I understand all of that. We have to be accountable. We spend public money. But also sometimes those variations are to do with historical factors, to do with local resources. I spoke to a leader the other day who of a trust that still hasn't got an electronic patient record. And I was talking to them about all sorts of exciting things. And they said, look, I haven't got time for any of that. I'm just dealing with the most basic challenges. So Jim, how do you get it right? How do you kind of reward success and incentivize success, but also recognize that we don't all start from the same position?
Yeah, so I think there's a few really good points in there, and I think the transparency is one thing. So we are trying really hard to gradually keep making more things available, more data available, so people can understand how they look and compare with others. On the conditions point, you made a point earlier on as well. Try and give everybody good conditions, a reasonable set of conditions for success, whether they are payment reform or in the oversight system or decision-making processes, capital investment to help address some infrastructure problems. And when we're looking at variation, you can very quickly get the point of saying that's understandable because it's a RAC hospital and everybody's walking around all the time having the ceiling protocol or something like that. But also then the other kind of variation that we need to tackle, where you can look at two places that look almost identical, often very close to each other, getting very, very different results on a specific issue. We've got to get better at understanding and differentiating on those things, get everybody on the pitch with a reasonable chance. So over time, helping fix the infrastructure problems and the financial flow mechanisms and all the workforce supply problems in some parts of our system, etc. Give everybody a reasonable chance. Make sure the data is available. Make sure everybody understands that locally. And then they're asking their own questions in the board and in the clinical teams. And how's that possible over there when we can't actually manage to do that? And over time, that feel less like it's a local centre argument or discussion, the oversight system. It's more self-generating on the ground. And I know you're really keen, hopefully, to get into improvement. I think helping people deal with that with each other voluntarily, because the energy's there to do it, rather than the being forced or pointed to, or it's part of an arm wrestle about, I need some money to fix part of the building, that sort of thing. That'll take time from where we're at now, but what may start.
Last two questions, Jim. I'm very aware of taking up your valuable time. One's about primaries. So I would say, as I go around the country, Jim, that the biggest variable when it comes to integration, when it comes to innovation in terms of, for example, trying to stop unnecessary visits to A&E or whatever, is primary engagement. Where primary is organized, where it operates at scale, really amazing things can happen. Like you can see, for example, in East Birmingham. But in too many places, it feels like primary doesn't operate at scale, that it's hard to engage any more than a relatively small sliver of the local GPs in talking about change. And we know the kind of incredible pressures primary is under. How important do you think it is that in the context of the 10-year plan that primary is able to operate at scale? And how do we go about making that happen?
I think it's a really big part of it. It's a very central part of the neighbourhood care part of the 10-year plan, which I think is still pretty much the best part of the plan. It'll be the thing that generates most energy, maybe alongside the quality stuff. It's stuff we're all interested in. But you're right, scale is a factor, but also, thinking back to my early life in the NHS, there's a huge amount of work went into developing primary care leadership, developing relationships between primary and secondary care so people work together as equals rather than having this feeling that one was looking down the nose at the other or it was some kind of competitive thing over money. These things aren't always perfect, and they're not perfect now, but at least there was an effort that went into keeping people together, having the right mechanics, having the right conversations, making sure the dynamics were working properly, the relationships were working properly, people were being developed together. None of this works with one part of the system being really strong and another part of the system being very weak. It is easier in parts where primary care is at scale because it's more organised, it's more coordinated, it's more consistent. And the big trusts are really big entities. When they interact with individual practices, they're dealing with SMEs. There's quite a really big structural and psychological difference there in, how they work. So it's naturally easier as you got sort of big corporates talking to big corporates. There is a bit of that. We need all parts of the system to be as strong as every other part. That's another thing that will hopefully try to see moved on in this next period is developing every part of the system rather than one part at the expense of another.
And then finally, Jim, in various points in this conversation, we've touched on to issues of leadership, but I just want to end by going to the heart of it. It feels to me that often we ask leaders in the health service to do things, but we don't invest in leadership development. And this is partly we ask people to take on new roles. I think this is one of the challenges of PCNs. We suddenly ask GPs to run quite significant workforces, to do things in different ways, but we expect them to just kind of magically find how to do that rather than in investing in giving them the kind of skills and the support, the organizational development. And equally, I go to places and we're asking people to collaborate. It's really hard to collaborate. It's hard to put the needs of patients in the place ahead of the needs of your own organization, your own staff sometimes.
Yeah.
But again, we just push people in the room together and say, go on, you get on with it. You start, behaving heroically. How important is it for us to invest more in leadership and organizational development if we really want to do things differently and better in the NHS?
It's absolutely essential. It can't be a negotiable. And I think you've described a really accurate picture of the way you see it. I mean, all these things, collaboration is hard anyway, but in extreme circumstances, when everybody's skinned and really under pressure, and then you put young and experienced people in without the training and development and expect them to get fantastic results out of that. I mean, how is that going to work? Who would think that's a good idea? We have to be trying wherever we can to develop talent, get people in the right places, give them the right skills, give them the right opportunities, support and challenge in the right way. And I really benefited from that throughout my career. I've had a lot of personal development. I've had a lot of coaching and mentorship. I've had good experienced colleagues around me to look after me and stretch me and put me into uncomfortable positions, but know that they're there when it becomes too much. And first of all, we need to talk about it more. But secondly, we need to get organized about it. It's not something that can happen by accident. Talk a bit about different points in my career. I was a young finance director when we created the Northumbria Leadership Programme. We had absolutely no money and we could absolutely not afford to do it at the time. It's still going now. It's 25, 26 years old with hundreds of people who've been through that through that system to great benefit. A few weeks ago, I met with the aspiring chief execs groups, and it was absolutely fantastic. Because again, at a national level, you convince yourself people aren't up for these jobs. There was a lot of people in that room really up for these jobs. One of them told me the other day it was the best thing they'd ever been through. They thought they were ready before the start of the programme, realised they weren't, and now think they are because of what the programme's done for them. The problem is it's sporadic. It's not systematised. It's not as universal as it needs to be. It's not as consistent as it needs to be. But we're going to get out and through this through great leadership. And we've got great leadership, but it's too often accidental and instinctive. And we need to add to the accidental and instinctive with coaching, development, education, intelligence, all those things as well. And that's again, part of what we'll be trying to do. It's our job to create the circumstances and conditions. It's everybody else's to pull together and deliver what we need to do.
What a great way of ending our conversation. Jim, I'm so grateful to you for joining me, Health on the Line. I look forward to seeing you next week in Manchester.
Excellent. Thanks, Matthew. See you then.
And that just leaves me to introduce our latest Leader in 6 interview, which is with Lorraine Mattis, Chief Executive of the University of Suffolk Dental CIC, which I've been lucky enough to visit. And indeed, Lorraine and I appeared on the Today programme last week. My colleague Sarah Miller caught up with Lorraine a few weeks ago.
So what would you say is the most pressing issue for you right now? What's your biggest challenge?
Undoubtedly, workforce is the biggest challenge in the dental sector. So there's a lot for us to do in terms of improving access for local people and residents, as well as supporting the growth, retention of a dental workforce. And by a dental workforce, I mean dentists, dental therapists and dental nurses and beyond, because there are more than just dentists that add or support the profession of the dental profession.
Fantastic. And what's the area of improvement or innovation that you are most excited by at the moment?
The ability to set up an innovative new organisation that focuses on both delivery and also workforce. So it's addressing both access and workforce issues across NHS dental care. But also it's the ability to challenge the status quo. We are innovatively commissioned through the ICB, and it's with a focus on outcomes as opposed to historical activity metrics.
Great. Now, if you were NHS Queen for the day, what's the one reform that you would introduce?
That's an interesting one. I suppose there are probably a number of reforms, but one I think is probably important for all of us is but it's not necessarily particularly innovative, is just breaking down barriers and silos. When I think about primary care more broadly, we work in a very siloed way. So how do we completely eradicate those silos and we're working as one team, one function, delivering the care to local people and residents?
Lovely. And who would you say is the leader that you admire the most, whether that's a health leader or a world leader or someone that you admire, and why do you admire them?
I think the one that I sort of immediately sort of comes to mind is Michelle Obama, actually. I just find her inspirational. She's willing to challenge the status quo, and let's just be frank, she doesn't take crap.
Very good, very good. Now tell us something about yourself that is interesting and nothing to do with your day job.
So I suppose what I would say is I love, I've come from a family where we're avid athletic and sports fans. So I suppose if I wasn't in the health space, albeit sort of health related, I probably would have been an athlete in a formal world or life.
Fantastic. And then lastly, just a book or film or a TV series or podcast listening to that you would recommend.
Yeah, so there's one that was recommended to me, which is very cathartic, actually. It's called Let Them Be. It's associated with Mel Robbins. So it's that ability to let go of control, be calm, and actually control the things that you can control, which is ourselves.
Lovely. Thank you, Lorraine, for doing Leader in 6.
Brilliant. Thank you very much. Thank you.
You've been listening to Health on the Line from the NHS Confederation. Visit nhsconfed.org for more information about us and to register for events and webinars that delve deeper into the issues explored in this podcast.